Cool. Welcome, everybody. Happy Wednesday, and thank you for joining for another VMR. Um, Zavin here alone today. Unfortunately, Steph won't be able to join us, hopefully next week. But as always, very happy to see everybody and excited to hear about a case that somebody has and would like to share. As well as two folks to discuss the case with me. Valeria, if you and Gabriel in the chat can decide who does teaching, because I think he was signed up, but yeah, maybe y'all can message and decide. Okay, so while we wait for a couple of people to volunteer as discussants and somebody to share a case, I'll just recap the neuro VMR from yesterday and share some reflections. So it was a case that Sukriti actually discussed with Aaron, and I'm sorry, I don't remember who presented and who else was involved, but it was a case of a young guy originally from Ecuador, who had basically come in after a fall. He was carrying some furniture or something and developed blurry vision and then fell, and had also had some tongue biting, and also had this history going back a couple of months of sort of intermittent episodes of similar stuff and confusion and things. And so the discussants talked about the possibility of seizures as what it really kind of clinically sounded like, and how at this age in the 20s you could still have just kind of primary epilepsy that's presenting anew. You could have a triggered seizures from metabolic things which are reversible, or you could have kind of lesional epilepsy from infections or masses or AV malformations and things like that. So this gentleman also had on exam a facial droop, which was just the lower face. So it was a supranuclear sort of upper CNS localization of that. And on imaging, he was found to have a couple of small lesions that turned out to be neurocysticercosis, which is a parasitic infection, tinea solium, that is acquired from ingestion of raw pork or undercooked pork, and can then lay sort of dormant, create chronic cystic lesions in the muscle as well as the CNS, and very often presents with seizures, and is one of the most common causes of seizures in sort of endemic parts with that infection. So a very interesting case. It actually made me remember a case that really stuck with me. The way that I like to staff new patients when the residents and students admit new patients either during the day or overnight, and we're then kind of rounding as a team and meeting for the patients for the first time, I like to ask the student or resident to present the patient's story, just the history as well as their kind of initial physical findings at the bedside in front of the patient. I'm just curious, actually, has anyone done that in the chat? Will you say yes or no? Have you ever been asked to present the case basically not in a team room or out in the hallway with just the clinical team, but in front of the patient themselves? Yes or no in the chat, or say maybe if you don't understand the question. Okay, so mostly yeses. Okay, that's really good to hear. Gabriel, maybe no. I'm sure others aren't familiar. And for those who haven't done that, it probably, okay, so Carlos saying sometimes the HPI changes, and that's always fun. So if you haven't done this before, and even if you have, it's probably a little bit of sort of anxiety provoking to basically retell the story. But the reason I like to do it is that it gives us an opportunity to again make sure we got the story right. It gives us an opportunity to spend more time with the patient and it gives the patient an opportunity to mention something that they might have forgotten to mention, right? And in a way, it can also be effective to just kind of have the conversation right there, and it can kind of cut out a lot of the subsequent like re-asking of the same questions and stuff. And it allows you to kind of start observing the patient and the room and the surroundings and kind of start learning things about the patient. Valeria brings up the concern that it can be scary for the patient. It depends on sort of what the focus of conversation is, right? If you're going to be discussing the entire differential diagnosis in front of the patient, right? Maybe that's at a level that doesn't need to be all transparent. But just a part where you're basically just retelling like the story of the symptoms and the narrative and stuff. It's the patient's own, right? So that part isn't so bad. But anyway, so I was making a sell to my team. This was towards the beginning of the block. I was like, I know some of y'all haven't done this very much, and it's a skill, right? Talking to the patient in front of the patient can be new, and you can get better at it. But believe me, it's worth it for all of these reasons that I already just told you guys. So anyway, this patient had been admitted with some focal neurologic sign, and on a CT in the ER, there was a concern of a brain mass. And they were awaiting an MRI, and that was the reason for admission. So we go in, and the patient or the resident kind of recaps the story, and the patient says, oh, by the way, I forgot to mention, now that you just said something that made me remember about how 15 years ago at my friend's wedding in Mexico, we were having a wedding. It was a big party, and we had a pig, and that was going to be our dinner. So we slaughtered the pig, but when we like cut the meat, there were just like all these white spots in the muscle, of the pig, and it didn't look right, but like that was our meal, that was our dinner, and we just ate it anyway. And then somebody had said maybe we shouldn't eat it because it can, if we eat this, we can get seizures or something, some brain disease or something like that. I don't know if that's relevant at all, but I thought I would mention that. And we were like, okay, you sounds like you might have neurocysticercosis, which is what the patient turned out to have. But it was just a great example of how a lot of times the whole story is difficult for us to elicit. It's difficult for patients to remember, and that history taking is iterative, and how the bedside presentation can actually help to facilitate that a lot. Anyway, fun little story, but a great case from yesterday too. And it seems like Carl, thank you for volunteering again. And Amanda also volunteered. That's wonderful. And we're still looking for a case, is that right? Travis, welcome. I saw you just signed on. Do you by chance have a human DX case for us or something?
I'm sure I could find something in the folder, but I'd present one, but I have a babysitting duty right now.
Okay, no worries. It looks like Anne Marie has a case she could share too.
Yeah, perfect. I'm happy to present a case if no one else has one.
Okay, last call. Any takers of the case? Going once, going twice. All right, Anne Marie, we'll go with your case. Say hi since you're unmuted, and then Carl and Amanda, please introduce yourselves too and get underway.
Hi everyone, my name is Anne Marie Kumfer. I'm a hospitalist at UNC, and I presented a case that was trickier than I remembered on Monday. So my sincere apologies, Rebecca. I'm so sorry. But this case I think should be less tricky.
Awesome. Hi, friends. I'm Carl. I'm a PGY2 internal medicine at University of Colorado, and currently applying to rheumatology, so very exciting. This is my second time being here ever and first time being a discussant, so looking forward to it.
Welcome, Carl. Really happy to have you. Amanda? Hi, Amanda. Are you able to unmute and introduce yourself? Or did Amanda freeze?
I think so.
It looks like she might have frozen. Okay, that's okay. Hopefully she'll be back in a minute, but just in case, is there someone else who would like to discuss in her stead? Gabriel, thank you for volunteering to present the case too, by the way. Okay. Hopefully she'll rejoin us anytime now, but let's have a backup in case she doesn't come back in a minute. Anyone else would like to discuss Anne Marie's case? I have no doubt that it will be a very fun one. Okay, Amanda came back. Amanda,
oh my God, what happened? I have some problems with connection, but I'm back. So I'm sorry, and I am Amanda. I am from Brazil, and I'm so excited to be a discussant today.
Amanda, what do you do in Brazil?
I am a fourth year medical student, and sometimes I like to read, I like to go out, I like to drink with my dog.
Awesome, great to meet you. Excited to discuss with you. So cool, Anne Marie, you want to tell us about the patient?
So the case is a 70-year-old male presenting with renal failure. The patient presented after recently starting dialysis as an outpatient, as the nephrologist wanted further evaluation. Had worsened creatinine over the past 2 months and ultimately started dialysis. He had chronically taken naproxen in the past, but was instructed by his primary care provider to stop 1 month ago with the increasing creatinine, but it did not improve at that time. He had not noticed any specific changes in urine color, was still producing some urine, but it was decreased in quantity. No fevers, night sweats, or recent hemoptysis. Did have a small amount of sputum production, and no nasal congestion or epistaxis. Does feel winded when he's walking around, which he feels like is just being deconditioned to his recent illness, and can walk about 10 feet. No orthopnea or PND noted. He has had some poor appetite, but no skin rashes, nausea, vomiting, or sick contacts. And I'll leave it there.
Thank you, Anne Marie. Amanda, do you want to go first with me and just maybe share how you think about this chief problem, renal failure, and within that approach, how you apply what we heard in the HPI?
Yes, so in that case, it's important to consider the age. It's a younger male and with failure renal. I think glomerulonephritis is a hypothesis, and apparently don't have infection because no fever or some hemoptysis or other symptoms associated. And it's a bad case, and it's worsening, and it's a chronic case. So I think this time we need to have consideration this point.
Thanks, Amanda. I totally agree with you. Carl, did you, let me just highlight one thing you said, that, you know, the patient's kind of background and age are very important. The time course you highlighted as very important. And in this case, you know, 2 months is pretty quick to end up, you know, with needing dialysis. And that's the other thing that you highlighted, which this isn't just any renal failure, right? It's severe. It's very advanced, requiring dialysis. So I think those are all really important to tease out, like you did. Carl, what would you like to add?
Yeah, I completely agree with everything Amanda brought up there. I think, to me, the time course is what's most striking, and certainly I would echo what's been brought up in the chat with sort of this relatively abrupt, you know, subacute at the latest sort of time course of renal failure. Certainly one of my can't miss diagnoses would be something like an RPGN. I'm hearing this gentleman has maybe some pulmonary complaints that kind of clues my thinking maybe into one of the pulmonary renal syndromes. And I think also too, it'll be helpful to get his past medical history, kind of frame this in terms of, well, does this guy have any of our typical sort of predisposing conditions? Does he have poorly controlled diabetes or longstanding hypertension or known autoimmune disease? I think we'd frame this case very differently if he were to have one of those versus if he didn't, and this was just, he had normal renal function at baseline and sort of no other reason to develop this. But absolutely, and of course, seeing some data, seeing a UA and a renal ultrasound would be helpful to sort of characterize this further, exactly what we're dealing with.
Brilliant. I think in terms of your question of, you know, predisposing conditions for CKD, as well as, again, this kind of time course, it would really be helpful to know like what the baseline creatinine is, right? Because if this patient had a normal creatinine two months ago, right, and we've gone from normal to basically ESRD in this very short time frame, the thoughts may be very different from, for example, if the patient did have diabetic and hypertensive CKD and the baseline creatinine was 3 or 3.5, you know, at that point the GFR is low enough that just a little bit of incremental decrease, right, could start to trigger indications for dialysis and initiation, and the insults would actually, which created that decremental worsening, wouldn't have to be as bad, right? So for example, somebody with, you know, CKD with a baseline creatinine of 4 taking a bunch of NSAIDs, okay, fine, I can see how that might tip you into, you know, needing dialysis. But somebody with normal kidneys taking a bunch of NSAIDs, not really, right? Unless this is a completely different mechanism of just like really severe allergic interstitial nephritis, you know, from the NSAIDs. Just the prostaglandin mediated kind of pre-renal mechanism shouldn't take normal kidneys and put them into complete failure. Yeah, you mentioned the UA, Carl. What other sort of initial kind of workup is triggered for you when thinking about AKI?
Yeah, so I think this is where we get into kind of our classic categories of like pre-renal, post-renal, intrinsic renal. And to sort that out, in addition to the UA, the renal ultrasound, in a case this severe, certainly I think some urine sodium, urine creatinine, urine osms would be helpful. Of course, we want a good physical exam and some basic labs. That's kind of where I would start.
Perfect. And you know, in an older man, that post-renal kind of obstructive category, you know, the most common place where urinary tract infection obstruction happens is the bladder neck and at the level of the prostate, right? So a bladder scan, ultrasound, a lot of times can make the diagnosis, or kind of rule out the vast majority of kind of mechanisms of obstruction. Okay, very good. Amanda, anything else you want to add before we move on?
No, that's fine.
Okay, perfect. Thank you.
The past medical history included hypertension, which had been well controlled, as well as a pulmonary embolus, which had occurred several years prior on anticoagulation. Also was in a different hospital last week for a stroke. He was reported to be like monitored overnight in the hospital, was not sure exactly what caused the stroke, and the imaging was not available, but reported that he got a TTE that did not show any abnormalities. Further history, he also notes that about 3 months ago, prior to this starting, he had a few episodes of pneumonia. It was actually first noted incidentally. He was getting a Followup CT scan for the PE and noted to have infiltrates on the CT scan, had been treated with several courses of antibiotics, like augmentin, and hadn't responded to the medications, but had not been on any recent antibiotics in the past few months. Medications include aspirin, as needed acetaminophen, allopurinol, apixaban, and colchicine PRN. Sorry, he also had a history of gout. As far as social history, prior 10-year pack-year history of smoking, but no recent use, no alcohol, herbal medications, or other drug use, no recent travel, and was sexually active with his spouse. And I'll leave the second aliquot there.
Thank you, ma'am. Amanda, Carl, first of all, do y'all have any follow-up questions, clarifying questions for Anne Marie?
So I'm thinking if these diseases are related with the kidney, but I don't know, like a stroke or pulmonary embolism, and I was expect the diabetes and he doesn't have, so I am confused.
I'm a little confused too, Amanda. Definitely sort of an interesting, right, thing that just in a very short time course, right, in the same kind of period of time, he just had all these other things going on, right? Like, what are the chances that, you know, his kidneys going from okay to really bad, and him having all these pneumonias, quote unquote, and the strokes and all these things are totally unrelated, right? There's probably some narrative, either totally unifying or sequentially kind of causative, that explains the temporal kind of overlap. Carl, please go ahead. I'm sorry.
No, that's okay. So I think we got some really rich information there, and a few things specifically come to mind. Number one, I think as other folks certainly are realizing as well, like this recent history of like questionable pulmonary infiltrates with sort of inadequate response to antibiotics in the same time course as this guy's having renal failure, raises my antennae further for something like a pulmonary renal syndrome. So I think I'm still very much on that train. Other things that have entered my mind, certainly with recent antibiotic use, you always have the possibility of kind of a drug-induced nephrotoxicity there, whether that's an ATN or an AIN leading to this guy's renal failure. It would be interesting to know to get sort of a complete med rec of what antibiotics he was on and for how long. And then sort of my next bucket, as far as my differential, hearing that this guy's had prior unprovoked VTE and maybe he's a vasculopath with this recent stroke. Could this be something vascular as far as, you know, I'd already mentioned like the small vessel vasculitides would be like your pulmonary renal syndromes, but could this be some sort of a large vessel phenomenon, whether like a renal artery stenosis or like on the venous side, if this guy's got a clotting predisposition, could this be like a renal vein thrombosis? I think as far as pertinent negatives, hearing that his hypertension was well controlled is helpful because now I'm less inclined to blame this on sort of your garden variety hypertensive nephropathy, certainly with the time course as well, suggestive against that. So I think we have a good starting differential here.
Absolutely, and I love some of the kind of patterns that you're recognizing that you mentioned. It's very common for pneumonia to be misdiagnosed. You know, the most common cause of sort of an inflammatory syndrome in the lungs is infectious, right? Viral or bacterial. So a lot of times when you have, you know, an overlap of pulmonary symptoms or systemic inflammation with something in the alveoli that isn't supposed to be there, right? You call that pneumonia and treat it as such, and 95% of the time you're right. But there's going to be some percentage of the time where you're actually wrong, and it was an autoinflammatory or sometimes malignant process in the lungs that causes essentially very similar kind of clinical presentation. But of course, the response or maybe non-response to antibiotics is something that that should clue you off, as well as the presence of other symptoms that kind of fit with some of those autoinflammatory things, like, you know, like vasculitis and stuff like that. I want to actually let me share my screen for a second and kind of advocate for, you know, the early use of diagnostic frameworks, even when you think you're kind of noticing some, you know, some patterns. So this is the CP Solver's schema for intrinsic AKI, right? Intrarenal AKI. And within it, as you see, it's sort of subcategorized into the different parts of the kidney, right? The glomerulus, the tubules, interstitium, and the actual sort of vasculature that feeds the renal parenchyma. And then the actual named kind of diseases are listed under each one, right? And I think, you know, even if at the very early stage of just like hearing, you know, this patient developed severe kind of progressive AKI, you know, looking at this framework is really helpful in order to trigger the iterative hypothesis testing and iterative history taking and iterative physical diagnosis and lab evaluation that, you know, that leads us to our diagnoses, right? So we may not have recognized immediately that, oh, wait, the recurrent pneumonias are funny. What if those are, you know, what if that's pulmonary vasculitis, right? But if we had looked at this list, suddenly we might have generated that idea, right? Or for example, you know, interstitial nephritis. Oh, NSAIDs can cause, you know, renal failure in more than one way. Wait, which antibiotics did he get for all these pneumonias, right? And suddenly we're again kind of gathering a more detailed history than we may have before. In the vascular category, a lot of these conditions, these thrombotic microangiopathies, right, cause both potentially microvascular and macrovascular thrombosis. And perhaps he has antiphospholipid syndrome, right, accounting for these PEs and strokes, you know, if they were true. So I think a lot of times, especially for the more common things that, like, in our mind, it's like, oh, you know, we're good at the AKI schema, right? But even so, sort of being systematic to look at the more comprehensive framework early on can help be ahead of the game, especially when clearly there's not like a slam dunk diagnosis that's jumping out here. Henry, you want to take us forward, please?
Uh, Labs and vital signs showed a temperature of 36.1 degrees Celsius, a heart rate of 101, respiratory rate of 20, and blood pressure of 109/76. The oxygen saturation was 95% on ambient air. The exam showed a left facial droop from the prior stroke, distant heart sounds without murmurs, some faint bibasilar crackles in the lower lung fields without wheezing. And then the abdominal exam was normal. The skin exam did not show significant edema. Did have a tunnel dialysis line in place that did not look infected. And then there were also SKs scattered on the back, which had been long-standing. And then no CVA tenderness felt. Lab showed a WBC of 10 with a normal diff without eosinophilia, a hemoglobin of 11.4, platelets of 171, sodium of 138, potassium of 3.5, fluoride of 95, an anion gap of 26, bicarbonate of 17, a BUN of 50, and a creatinine of 4.4. The calcium level was 9. The hepatic function panel was normal, aside from an albumin of 3. Complement levels were normal. HIV was normal or negative. Hepatitis panel was negative. ANA was 1 to 80. CRP was 75, with normal being less than 10. And urinalysis showed greater than 180 RBCs with 3+ protein and a urine protein creatinine ratio of 1.7. Renal ultrasound showed mild increased echogenicity, but no hydronephrosis. And then I will leave it there.
Thank you, Anne-Marie. Amanda, what do you think? Let's actually, just in the interest of time, let me say quickly that the exam, it doesn't provide us too much new information here. There's some pertinent negatives, and let's just assume that this patient doesn't have 1,500 cc's in their bladder. Otherwise, hopefully, we would have, felt it. But so, Amanda, react to some of these labs. How do you interpret them, and what questions do you want to raise for Carl maybe to help you answer?
So I think the kidney function is okay, but not okay with this exam. So I pass to Carl to think what he wants to know and what he wants to say, because I'm really confused.
That's okay. That's okay. So let me try to guide you a little bit. Okay. So in my mind, the single most important kind of test, as far as like kind of lab or imaging tests for renal failure, is to actually look at the product of the kidneys, the urine, right? The UA. So in the UA, in the urinalysis, we see that there's a lot of red blood cells and there's some protein in the urine. Is that helpful at all, especially when we think back to, the differential that we had before, which was, glomerular processes, tubular processes, interstitial, and vascular processes? Amanda, you still there? Uh-oh, Amanda's connection might be giving her trouble again. Okay, that's too bad. Hopefully she'll be back soon and rejoin us. But Carl, what do you think of that UA?
Yeah, as a lot of folks have said in the chat, nephritic syndrome for sure. So presumably would be nice to see if we had RBC casts, if maybe we, the nephrologists were able to spin the serum down, look for RBC casts and muddy brown casts and all that. But I'm going to presume this is glomerular hematuria with, we also have subnephrotic proteinuria. We have this subacute time course. We have an abnormal pulmonary exam. We have elevated inflammatory markers. This constellation to me is all screaming potentially a small vessel vasculitis, RPGN, pulmonary renal syndrome, sort of until proven otherwise. I agree with Hans. I think for the sort of second time in a row I've been here, I'm going to say I think we absolutely need a renal biopsy, kind of expeditiously in this guy. I would also want to get a chest CT to sort of characterize what's going on in his lungs. And then I think, as some other folks have mentioned, some supportive serologies that we could send here would be ANCAs, both by immunofluorescence, and I learned when I did rheumatology consults this year, it's not good enough to just look at the immunofluorescence. You should send the P-ANCA and the C-ANCA individually so that the lab can do them by ELISA, better sensitivity. So all that is to say, ANCAs, I would send an anti-GBM. I would send anti-phospholipid studies, as others have mentioned. And I don't know, this to me is almost so convincing that I would consider, with the help of my colleagues in rheumatology, of course, potentially like empirically immunosuppressing this guy before we even have biopsy results, depending on what the chest CT shows, if that's compatible. Some of the labs come back.
Wow, Carl, you're going to be an amazing rheumatologist. That was that was great. And Amanda, sorry you lost connection again, and welcome back. So Carl basically was just saying how all of those red blood cells in the urine are a sign of glomerular bleeding likely, and glomerular inflammation likely. So in this context, we have concern, for such a rapidly progressive glomerulonephritis potentially, that I agree with you, Carl. It's worth not allowing any more nephrons to sort of irreversibly be lost. And in this context, starting high dose steroids even before the final diagnosis is established, just because there's only so many things that this could be, and all of them almost do benefit from immunosuppression. The one thing not to miss is that scleroderma renal crisis can often present sort of in a very similar way to other thrombotic microangiopathies, and sometimes can even kind of mimic a glomerulonephritis. It's not typical to have hematuria, and this patient isn't hypertensive and doesn't have an established diagnosis of scleroderma, nor are they of the sort of epidemiology, age, gender, et cetera, to be most at risk. But a lot of times this is how scleroderma first presents, is just progressive renal failure, and that's one condition in which steroids actually can be associated with worse outcomes. It's worth just kind of, again, assessing that risk, looking for any skin, or mucocutaneous fingernail palmar changes that can be suggestive of that diagnosis. But barring any strong signals for that, which we don't see now, I agree with your steroids, all the serologic workup, and urgent biopsy. Amanda, any other thoughts or questions you want to ask me or Carl?
No.
Carl, how does that help us? That can help us maybe call these recurrent pneumonias just kind of pulmonary vasculitis and potentially something that was misunderstood. But what about the strokes? Would ankylosing help explain strokes?
I think potentially, I think you can get, and I'm not sure the exact frequencies, but certainly it wouldn't be off the table to me that you could get CNS involvement with any of these vasculitides. Again, maybe in a year or two, I'll be able to tell you like which ones can do it more often, but certainly I would entertain that as a possibility versus just this guy has uncontrolled systemic inflammation. Is he having a stroke just in that context? But I think actually that's a really good point as far as kind of when the dust settles on this renal workup, would we want to look at his intracranial vasculature too? I think maybe if we, I presume his neuroexam now, like he's at baseline other than this like facial droop from the recent stroke. So he's not having like active like encephalopathy or anything like that.
I can give you the MRA if you would like it.
Yeah, so sounds like we did go down that path. That would be great. Whenever you were gonna get to that, Emery, but yeah. I think I'm ready to see some more data.
Yeah, so the chest X-ray did show bibasilar reticular opacities and some linear opacities in the left lung. I don't have a CT scan of the lungs. The MRA did show multifocal acute bilateral frontal parietal cortical and subcortical infarcts, and then a new small infarct in the left posterior occipital lobe, and then a right cerebellar infarct, and then moderate narrowing and decreased flow related enhancement involving the right distal V3 and proximal V4 segment of the vertebral artery, with relatively symmetric increased caliber of the carotid terminus and interior circulation. And then at this point, and the MRA was without contrast, by the way, just because of his creatinine. A diagnostic test was sent.
Thanks, Anna Marie. Amanda, are you with us, Amanda? Yes. Yay, Amanda's here. Okay. I know this has been like a super complicated, challenging case, and I applaud you for engaging with it and sharing some really great ideas from the beginning, and being honest when later on you were just confused, and that's perfectly normal. But I'm curious if you could help me think through this MRI, right? So let's look at this. Okay, there's multifocal acute bilateral, so frontoparietal and cerebellar occipital infarcts. Like they're everywhere, right? So does this feel like sort of like a traditional stroke that you think of? Or does this feel like a more like diffuse kind of process?
Like a diffuse process.
Yeah, right. And that we've been using this word like vasculitis when talking about, right, the kidney glomeruli and the lungs. But does this potentially fit with inflammation of the blood vessels, what we're seeing on the MRA?
I don't know what to say.
I think it could, right? Because these are the MRI is showing areas of sort of hypoperfusion, basically, right? And the way that vasculitis causes a lot of its end organ manifestations is that the inflamed blood vessels end up like causing narrowing of the actual lumen of the blood vessels, or they cause little strokes on the inside walls of the blood vessels. So it is potentially compatible to just have multiple kind of patchy areas of infarct in the brain that don't necessarily localize to like a single large named artery, right? Which is how you usually get the more like traditional strokes. Back to your question of which vascularities tend to involve the CNS and which tend less to. I think I don't know the exact kind of numbers either, and I think ANCA disease can involve the CNS vasculature, but there are other things on the differential. It's not that rare for older individuals to present with lupus, and certainly lupus can cause CNS vasculitis. It can cause obviously the renal disease, but also pneumonitis and an involvement of almost any other organ. So I think there's still a bit of a differential here. And I don't know if anybody wants to kind of put their nickel down. No, I think it's hard to say for sure, but I'm wondering if Amanda and Carl, if y'all have a disease you most suspect and why. Carl, why don't you go first and then Amanda?
Yeah. I am going to put my nickel down on GPA, formerly known as Wagner's. I think at least of the illness scripts I have in mind, this probably ties it all together the best. And this gentleman, 70-year-old male, I think, as far as I know, sort of fits the epidemiology in that you see kind of onset of this in older males, maybe more than some of the other autoimmune processes.
I think if it's possible be a glomerulonephritis after the stroke or after the problems he has. So I'm not, kidney is not my thing, so I did my best, and I think it can be some glomerulonephritis after the stroke or the pulmonary embolism.
Thanks, Amanda. You did great, and I think the kidney is a little bit less your enemy now that you have worked with us on this case. So thank you for that. Yeah, I think I'm with you, Carl. I won't dissent. Anne-Marie, you want to tell us what happened and teach us some things along with Valeria?
Mm-hmm. So the MPO, ANCA titer, came back positive above 60, and then a renal biopsy showed posse-immune focal necrotizing and sclerosing glomerular nephritis with 35% cellular to fibrocellular crescents. There was also acute tubular injury and moderately severe arterial sclerosis. And so the final diagnosis was ANCA vasculitis with renal, pulmonary, and neurologic involvement.
Thank you, Anne-Marie. Before we get into the teaching points from Valeria, anything you want to share with us about this case in terms of just what you learned from it and some of our kind of open questions we had about the frequency of neurologic involvement and stuff like that, Anne-Marie?
I do not know off the top of my head. Let me see if I can figure out like how often there's neurologic involvement with ANCA, but I know it can occur as any vasculitis. I think the thing I thought was most interesting about the case was just kind of outpatient, some of the infiltrative lesions that were seen and the creatinine that was like going up, and kind of thinking about that globally, even though there's a lot of other things involved. So yeah, I thought it was an interesting case. It was a question about whether the allopurinol could have contributed, because that can sometimes be associated with the ANCA vasculitis, but it could have just been kind of regular ANCA vasculitis as well. Was treated with high-dose steroids and then got both cyclophosphamide because of the CNS involvement as well as rituximab.
Did you get better?
There, I think, was dialysis dependent for a while, but there was improvement with treatment.
Awesome. Well, thanks so much for sharing the case, and thank you, Amanda and Carl, for discussing with us. Great job. Valeria, you want to summarize the teaching points and conclude the hour?
Yeah, sure. Really great case and discussion. So Amanda started us with a case asking who is the patient and the facts that could contribute to kind of narrow our differential. And so the age of the patient was the first fact that kind of point or jumped it out. And he also asking for comorbidities, as like if the patient had diabetes or hypertension or any autoimmune disease. And also in a renal case, the baseline renal function, the baseline creatinine were also questions important to kind of have an idea of who was the patient. And also his exposures, like in this case, the patient had an infection, so the use of nephrotoxic antibiotics was important. And also the time course, that is something that Carl pointed out that kind of at the end kind of got the diagnosis because the rapid progression to dialysis was something that kind of makes us think of RPGN. And in that case, also, well, the fact that the creatinine was also very high and the patient was in dialysis, we had to think, and Sabin kind of showed us the schema of acute kidney function, sorry. And so to differentiate between pre-renal, intrarenal, and post-renal, and the intrarenal, because of the hematuria of the patient, differentiate between glomerular, in which we will think about autoimmune disorders, PIGN, or cryoglobulinias, and in the kind of interstitial tubular etiologies such as ATN and AIM, and in the vascular side of the etiologies, thinking about TTP or hemolytic uremic syndrome or APS. And then we were thinking, and it's something that was really interesting because Carl pointed out very early in the case, and it was the fact that the patient had some respiratory symptoms, such as sputum, and felt winded when walking around. And he very early on thought about the possibility of some renal pulmonary syndromes in which vasculitis could compromise, and especially ANCA-positive vasculitis could compromise both the kidney and the lung. And then another interesting fact was the fact that the patient had recurrent pneumonia episodes. And so we will think about the patient had any level of immunosuppression or a possible autoimmune etiology or an infection that could be predisposing to this recurrency of infections. And also an schema that I really like is the antibiotic failure schema, because you can kind of separate the causes of failure on the antibiotic treatment between the fact that not a right dose of the medication, or maybe the wrong organism you've been treating, or maybe not even an infection etiology, such as this case, that it turned out to be something autoimmune, or thinking about malignancy. And then the history of a stroke and a PE in the patient made us think of hypercoagulation. And Carl thought about the fact that it could be part of maybe a nephrotic syndrome, or maybe a part of a nephritic syndrome that could have kind of an etiology in baseline, like lupus or APS. And then the exams and the hematuria with myproteinuria gave us a diagnosis of nephritic syndrome. And well, the suspicion here was that it was a glomerular hematuria, in which case we will find RBC cast, dysmorphic RBCs, and acanthocytes. And Carl gave us a really good differential in which he prioritized rapidly progressive glomerulonephritis because of the time course. And in that case, we have to rule out vasculitis, especially ANCA-positive vasculitis, sorry. And other etiologies such as lupus and post-infectious are also causes of nephritic syndrome. But a pearl that I picked up from the chat that Mario mentioned was the fact that the patient had normal complement levels. And so in that case, we needed to prioritize RPGN and fibrillar glomerulonephritis and IgA glomerulonephritis as well. And then we were kind of surprised of the findings in the MRI because the patient had diffuse bleeding, and a bleeding that could not be explained just by a focal stroke, and made us think of the possibility of an inflammatory vasculitis. And Sabin taught us that ANCA-positive vasculitis can have CNS involvement, and in which, well, the final diagnosis at the end was an ANCA-positive vasculitis that causing the rapidly progressive glomerulonephritis and also the pulmonary involvement. And so great case, and thank you everyone for the discussion.
Thanks, everyone. Have a great day.
Thank you all.
Vale, that was awesome. Good work.
Thank you. I was really nervous.
You did great. It's perfect. All right. Hope you have a good day.
See you guys.